Tuesday morning for the Primary Care Commissioning Committee. We've got apologies from Heshan and from Nicola. We are quorate. Declarations of interest. Mick Corley's joined us and he's just declared no interests. So we know our GPs, our colleagues are conflicted on any of the decision making. The agenda today looks quite straightforward. So we'll go on to the minutes on 3A.
My interests haven't been updated on here for some reason.
Okay.
So I've started with my role as on the Derbyshire ICB as the designate audit chair, and I will be starting at Nottingham Healthcare Trust as their audit chair on the 20th of June. I have given my declarations to Cheryl. I think it's just working its way through.
Thanks, Sue, for that. We'll add those on for the meeting. So if you can approve the minutes, please, back from 14th of January. These are checked outside the meeting. Okay. No hands, so take that as agreed. Thank you. Any matters arising? Andrew, anything you want to mention?
It might be worth, I mean, obviously the guidance regarding staff needing to be vaccinated to continue in primary care, that's now formally the decision by the government's altered. So we had assessed where we stood, and there were some risks. There were mostly in non-patient facing roles, but roles that would involve being close to patients. So we'd taken the decision that obviously primary care generally is delivered from small premises where you can't really be completely backroom staff, and I think most of the bigger trusts had made the same decision actually. So we did do that action. So even though it's now kind of null and void, as you like, we did it, and there were some risks, but not anymore.
Okay, thank you. Any questions on that one, Nick?
Just on the action I had around the absence tracker. So I've jumped in there. Was there any questions for Andrew on that last one on the vaccination of staff? On the action that I had for the absence tracker, I think I misinterpreted it. I thought it was the status, the go live of the tracker and reporting into the tracker, which is what I'd fed the action back on. But I think Hesh had asked it's about who can CCGs or ICS get access to aggregate information for sort of strategic planning. So I've asked the question to NHS England IT, and they're going to come back to me, and I'll update the action in that term of who can access the aggregate data.
Thanks, Nick. So on the action log, then we've got the first one is being deferred. Idris and Victoria with that one, and then the next three are completed. And just to note, Nick's comment on his action that he'll update the action log when he's got further information. Victoria.
Yes, just in relation to that press release, we did do a press release a few weeks ago, and it did refer to the positive staff survey, GP patient survey results, particularly in relation to the positive response that we've got for our receptionist in primary care. So it was made reference to as part of that general press release. So I think that action has actually now been completed, Sam.
Thanks for that update, Victoria. So we'll mark that one as completed. Thank you. Okay. Next one, 3D terms of reference. Andrew.
Yes, thanks, Sam. We previously extended the terms of reference until March, but obviously now we will still be sitting as a primary care committee for the first quarter, or at least the first quarter of 2022-23. So I'd like to propose that we extend the terms of reference till then. We've said we're scheduled to hold another committee in 2 months, and then the intention is to hold a further final committee at the very end, towards the very end of June, so we can ratify anything that we've needed to do virtually. Just ask for that approval, please.
Committee happy to approve extension of the terms of reference. Okay, thanks all. And on to the ICS transition update. Idris.
Thanks, Sam. Just a brief update, really, because I think some of the key developments were discussed at the last meeting. So, as we know, the dates for transition into the new region and the Nottinghamshire system has been postponed to bring it in line with the ICB expected establishment on 1st of July. We have actually progressed, I think, quite well in terms of most of the transition programme. Of particular note, the shared services that we have with South Yorkshire, we've just at the stage of, I would say, finalising, not quite finalised, but finalising in terms of which transferring 1st of April, which transferring 1st of July, and which are going to be on a longer sort of term. From a primary care perspective, probably one of the key issues is about GPIT, and we will retain the current arrangements for that, and that gives us, I think, greater continuity and security around the continued IT sort of support for GPs. The ICB executives are in the process of being recruited. We are expecting imminently the announcement of the 3 executive positions on the Nottinghamshire ICB. So that would be the Director of Finance, Chief Nurse, and Director of Integration. I thought it might have been already announced and I could have told you who it was, but it hasn't been officially. But if it is during the meeting, I'll let you know under AOB. In addition to that, South Yorkshire have made announcements. In particular, Lee Youthwaite is the Director of Finance designate appointment, and Cathy Winfield is the Chief Nurse. Will Cleary-Gray's Director of Strategy, and Christine, I'll remember her name now, Chris Joy is the HR sort of lead, and David Crichton, particularly pleased to see a GP as the Medical Director for the South Yorkshire sort of ICB. So they're all designate appointments, so things are moving forward. We received yesterday the formal notification of the extension and the new target date of the 1st of July. Their phrase, not mine, target date. And the transition programme sort of continues. In terms of the ICS in Nottinghamshire, the other thing that's probably worth noting is that they've stood back up the ICS board and other governance arrangements for their ICS, and that will continue into Q2. So they had stood that down just before Christmas to have the ICB in shadow form, but with the delay, they've decided to re-establish those.
Okay.
Victoria's leading on some of the detail around the transition, so she may want to come in and add anything.
Thanks.
I think that's fairly comprehensive, Idris. I'm not sure there's anything specifically. I would just say in terms of the GPIT, obviously we're really keen that that is a safe landing into the new arrangements. We've established a task and finish group amongst our digital and IT leads, and Tom is part of that, who's on the call today. What we've decided to do is obviously develop a list of the existing tasks and functions that are currently provided by the BBS service, and we're working through them to understand which of those services may or may not transition at a different phase in time. And our current thinking is that we're going to aim for a transfer of corporate services, which will probably happen in year, probably from the 1st of July, if possible, with then the transition of GP services for the end of the next financial year. So not do everything all together. But there's a lot of working through to think about, not least of which is the potential costings for the transition moving into NOTS through their HIS system. His provider rather. So yeah, working through some of those details, Sam. Happy to come back at the next meeting and give you a further update.
Okay.
Just on that last point, sorry Sam, although we are still part of the South Yorkshire and Bassett Law system in North Eastern Yorkshire region, we are now part of the planning, the financial and planning arrangements for Nottingham and Nottinghamshire. So they will be submitted to the Midlands region. So that will cover the full 12 months. So there was some debate about whether we had to do planning for 3 months in North East Yorkshire and then for 9 months but fortunately common sense has prevailed, and it's all being done through the Midlands and Nottinghamshire.
Thank you. Eric?
Thanks. I was on the Nottinghamshire Clinical Exec meeting this morning, Idris, and Rosa has announced herself as the Chief Nurse Designate. So
well, there you know one then.
Yes. So the announcements are coming out.
Yeah, I think it's the world's worst kept secret, I think, already, as happens in the health service. But no official announcement has been made. But yeah, that's interesting. Thanks, Eric.
Thanks, Eric. And Andrew and myself attended the primary care transitions oversight group yesterday, where Ellie provided an update on the various work streams for the transition. Andrew, did you want to touch on anything from that?
I suppose the delegation agreement, we've got the first draft of the delegation agreement has been sent down for us to feed back on, to feed if there's any omissions that we'll need to do. I've sent it out to Idris and Victoria, but other members might want to take a look at that and feed in. I think the bit around there's a section around performers lists, and there's some sort of confusing about individual performance and how much we get involved in that as a CCG or as an ICB going forward, that I think slightly contradictory, but it probably just needs several reads to get through it because it's quite complicated language.
Okay, and just on that also, there was discussion around the development of the primary care strategy and the involvement of Bassett Law in that, and comms and engagement spoke around targeted events and panel events regarding comms and engagement.
Sorry, Sam, there's an event on the 16th and 17th, which I attended the first planning meeting for it yesterday evening. So the intention is to fully involve Bassett Law. I was going to have a chat with yourself, Victoria, about there's quite a few different streams in it. So they've basically broken primary care strategy up into 12 streams, which is a bit challenging for us to be represented at each of them. But I think some of them they're going to do it over 2 days. Fortunately, the first day is over Best Day. So on the 16th of March and then the 17th of March. So we'll have a chat, but the intention is to involve us. There's a first draft being sent out again, which I'll circulate. I've already sent that to, again, Victoria and Idris, but I'll send it more widely to the rest of the group afterwards.
Thanks, Andrew. Sue?
Does one of the streams cover enhanced services? Because I think that might be an area where we've got quite different approaches.
There's an area about, well, business model and commissioning. So I think so, but I don't think we'll get into the detail within the primary care strategy. Myself and Joe Lunn, who's sort of my opposite number in Nottinghamshire, we're having weekly discussions now about that. But the intention is really that we'll continue with our enhanced services and look at how they work over the first year and broadly, you know, sort of do a bit of a gap analysis on both sides, so that we might still have some differences in the following year into 2023-24, but they'll be broadly working towards equalisation. They might be contracted slightly different to start with. Thanks.
Okay. Victoria?
Yeah, thanks, Sam. There are a few things in there for me. So there is something about de minimis rule as well. So we obviously want to always build up, don't we? We don't want to reduce inequality or standard of provision at all. So I think that needs to be a principle of how we do that. The other thing for me is there's a bigger interdependency, isn't there, between the consideration of what primary care, you know, is recognised, how it's going to be recognised, how it's going to develop and mature, alongside the development of the PCNs and alongside the development of place itself. So there's a high level of interdependency also around the integration agenda. So it'd be good to feed into those conversations, Andrew, but it's kind of, to what extent is it a very transactional conversation as opposed to a strategic interdependency conversation? I'm not quite clear on yet.
Okay. Andrew, did you want to note anything from that?
Sorry, did I?
You want, yeah.
I think he's just agreeing with me.
Sorry.
Disagree.
Okay.
No, I mean, I think going back to Sue's point, I think what we do want to make sure is that we don't build too transactional element into the way that we work with people. That's the way that the Bassett laws have always been that way, and we've gradually moved towards more of a, I don't think I'd say trusting, but it's more that we have our conversational way and we agree the way that we're going to do things. We don't commission micro lessers, and I think there's a general feeling around all the primary care leads that that's the way we should go in. So I don't think there'll be a move towards having lots of different enhanced services, but we've got to have a bit of an honest assessment of what we do. So for example, at the moment we're putting microsuction into the practices, ear microsuction. We didn't need to have a discussion about contracting for it. We don't need to do that. We've already got an agreement that ear care is part of modern general practice. We already fund it via the baseline. So practices know they're funded. They know that microsuction is modern practice rather than ear syringing. NICE has said that years ago. So we didn't need to have that argument. We didn't need to thrash out a contract. They don't need to claim for it. We don't build all of those transactional costs into our relationships, and we don't want to reverse on that, I don't think.
No, but it's maybe that sort of approach that needs to be built into the strategy, you know, and that sort of concept as to where you're working towards might be something that could usefully be in that strategy.
I agree, Sue. I think that's where we use our influence to make sure that we don't get rid of the Bassett Law way, that we build on this. There's a lot of strengths in Nottinghamshire. There definitely are, but I think that's one of ours.
Yeah, that's the sort of thing I was trying to get at. I just didn't explain it very well.
Totally agree.
Thank you, Sue. We will capture that. Michelle, then Mick.
Thanks, Sue. It was just to update you that we are having regular meetings, Mick and myself, with colleagues both in Nottinghamshire and between NHS England teams about the finances and the transfer of primary care finance functions between those two NHS England teams. So we have a plan. Conversations are happening regularly around that to make sure that we have a safe landing as far as the finances are concerned.
Okay, and I think that came out of the meeting yesterday, didn't it, Andrew, in terms of assurance on the progress?
Yeah, we're having a lot of meetings at the moment. I had a further meeting with NHS England colleagues from both regions, and they fed back on that as well and said that they felt everything was really going quite smoothly in terms of the big risks around finance and that they were all being managed well. So there were no concerns about it.
Thank you. Thanks, Michelle. Mick?
Thanks. So I was going to just comment on Victoria's point, but if I can just probably add to that last conversation. So I think, Andrew, that's really helpful to hear that, actually, because I hadn't heard that feedback before. So that is good. And as you well know, we are working really closely together in the way that Michelle's described. On a personal level, I'm kind of less bothered about the kind of PMS side of the house and making sure we have the safe and soft landing for both from both a Bassett Law and a Nottinghamshire perspective at the moment. I think that's going as well as it could be, and we are, from a finance perspective, getting into a level of detail which gives me the assurance we are identifying the issues of an operational nature that will make sure that we avoid own goals. Because from my perspective, I'm sure colleagues will agree with me on this one. For me, 1st of April or 1st of July is all about making sure that we do have a continuity of our existing services and making it happen in terms of basically making sure our GPs still get paid, whether they're in Bassett Law, in Nottingham and Nottinghamshire. I think that for me is the priority and what I'm geared around. On the wider allocations piece, and I suppose I'm playing now to the whole issue around the pods transfer. We have, albeit at a high level, been given messages around the high level allocations around all of those areas. But I think as we get close to the following financial year, when formal transfers taking place, we're in a better position there just to work out and make sure we are properly secured in those finances. So I think there's further work to be done, and there's a TBC around that. Moving on then just to Victoria's point really around the strategy. I equally am hoping, Victoria, that we're getting a sense of shape, of direction, and describing where we are, and as opposed to potentially getting into that transactional detail, because that will happen. So I'm equally looking forward to seeing that shape, because I think that will then help. But as you've already alluded to, we need to make sure, from my perspective, certainly, that the identity of Basset Law and its representation is in the overarching strategy. So I think that will be something to be added to. So really just to support the commentary that Victoria was saying.
Thank you, Mick. Thanks. So that update was to note the similarly on the agenda primary care at place, an update. Victoria, did you want to add to that?
Sam, sorry, just to round that off, we also had a meeting about the functions that NHS England carry out on our behalf, which are very contractual, very transactional. And I've had initial assurance that the East Midlands team will carry out very, very similar functions. That was one of the concerns, because we actually have very good relationship with our NHS England local team, and they do quite a lot of this sort of the backroom stuff for us. But that risk seems to be, I'm just finally confirming it with their team. It's Anna Nichols down there, but it does seem to be something that's not as worrying as we once were worried. That's terrible English, but yeah, you know what I mean.
Okay, thanks for clarifying that, Andrew.
Okay.
Yeah, I was just going to add that bit in, because Andrew, we developed a table of all the functions that we were currently receiving from NHS England, and we wanted to be really clear that those were being considered and smoothly transitioned from one regional support offer and into another. And so that's a confirmation. But I've asked Andrew to make sure we've got it in writing, so that we've got something to point to if it ever falls down in the past, because we can't expect our NOTS colleagues to pick up everything, and there is an expectation that resource will follow through from one region to another. So I think that's been a really helpful piece of work that Andrew's supported.
Thanks. Yeah, so we've got the primary care at place update, Victoria. I know that we've got the draft delegation yesterday regarding that. Is that something for the next meeting then you want to put on?
Yeah, I think so, Sam, and an update around the strategy as well, I think will be really, really important. So yeah, I don't think at this point there's anything further to gain by conversation on that. I don't think we've got anything further to add.
Okay, thank you. On to the GP appointment data.
Thanks, Sam. Actually, I've noticed the chart that's gone out in the papers is a bit of an old one. I have previously sent out all the appointment data, but I'll send it out again after the meeting. So you'll be familiar with the pattern. We're quite a long way in terms of number of appointments above the national average. We've had since September a swing towards face-to-face appointments and away from telephone appointments, and we have fairly continual discussions with the CDs, Eric and Deepti and Kumar about that. And I think Deepti was saying that they're aiming for about 50-50 at Newgate in the long run, aren't they, Eric, on Wednesday? In terms of numbers, we're tracking at a very similar level to pre-pandemic levels now. We've gone slightly above that. It's very difficult to measure month by month. I know I send out the month by month figures, but it actually depends on the number of working days. And how the weekends fall as to whether you can directly compare, but since September we have been tracking slightly above the pre-pandemic levels, and that's our aim for next year is to continue in that way. The PCNs, I'll do it now, or the PCN update, have all submitted their workforce data, both and plans, I should say, both in terms of Rs and in terms of core staffing. So you don't want Rs increasing and core staffing going down, obviously, and both are due to increase. Obviously Rs are due to increase as their budgets go up, but also all have submitted that they plan to increase their GP levels and the rest of their staffing levels. So we anticipate that we should be able to meet pre-pandemic levels quite comfortably.
Okay. Any questions for Andrew? Okay, that one's just to note. Okay. COVID and flu update, Andrew, again to note.
Yeah, again, I've sent out the swathe of information. The COVID vaccine campaign continues, and we're already planning for the next year. So we did in February around 3,000 vaccines, and given our population and the population that we've got left to vaccinate now, I'm quite pleased with that. I've just made a note, but I've already sent it out. 340, just for the record, 341 firsts, 862 seconds, and 1,679 boosters. That's in our LVS site, so that's in our PCN sites. We also will have a share of the pharmacy vaccines, so probably another 100 or so. So I think we're around about 3,000 vaccines a month at the moment. Victoria, did you want to come in there? You're on mute.
I don't want to. You carry on your flow. It's just the good work. I was going to raise about. We've achieved nearly 500,000, haven't we now? When we combine all the first, 250,000, when we do all the first and seconds and the boosters, which is a phenomenal amount of boosting activity, vaccination activity, and a really good news message for Bassetlaw. So obviously something that we can celebrate as part of our comms and engagement work, I think.
Yeah, we should have gone by 250,000. I would have thought we've done it by now. So we were at we had about 43 to go on Monday. So given that we're doing around about 600 or 700 a week, we'll have gone past it by now. So it's a great achievement. Just to dampen the mood a little bit, 5 to 11-year-olds at risk. So at the moment we've got about 16% of them done. But everywhere is really struggling engaging that cohort. It's really low, absolutely everywhere. So the SYB average is 9.6. So we're almost double that. Newgate's done very well on it. I think it's worth noting with Newgate, they've done 25% of their cohort, which is, I think, but one of the highest PCNs in South Yorkshire. That they seem to have. But either way, it's a very low take up, and we know that that's the next group that we'll be aiming at, the healthy 5 to 11s. We've got about 9,500 in total. So that's going to be a challenge. The other things to note, we may have to say, making plans for future delivery. We approved a new pharmacy site on Thursday night. And that will be at East Markham, which is just off the A1 for those not familiar with the locality. So that covers out towards the Tuxford area, also helps for our Nottinghamshire colleagues. I think it'll be quite handy for the North Newark cohorts. So there's a group there that can come and access that. And they're a high capacity, so they've moved from Gringley on the Hill. So we have got a pharmacy site out at Misterton, which covers that locality, but it's the same people who can deliver up to 1,000 vaccines a week. So they've got the ability to ramp up. They're not approved for 11 to 15-year-olds yet, though. Most of the pharmacy sites aren't. So I think going forward, we're going to maintain the LVS sites, and we've got the 6 pharmacy sites giving us that geography. We have tried out the van. We've tried out a bus that went round and went to the localities, went out into the local employers. So we've got good engagement there, but we went out in the middle of a hurricane. It was last Friday, so we didn't get a great deal of take up, but as a trial run, it was worth it. I think next time we have a big campaign, and we really need to, the requirement for us over the next 6 months is to be absolutely prepared. If we do have another variant or we need a booster campaign quickly for whatever reason, then to be there. So that's another thing up our sleeve, as well as the capacity that we can soon ramp up in all the sites. So I'm comfortable we can do it, and that we can manage this. It's about 20,000, the spring booster campaign in total. If we look at our over 75 population and our 5 to 11s, noting that the 5 to 11 take up, if we manage to get 30 or 40%, I think we'll have done extremely well. And we know the over 75s take up is good, but we anticipate it will drop off slightly each time that we go out and do a new booster campaign. There'll be a slightly lower take up. So comfortable that we can do that, and we're already looking at the flu campaign as well for next year, and trying to decide how we can iron out any supply problems, particularly with the vaccine delivery for that. I'll just note flu, I sent that out as well. Again, successful campaign, pretty much across the board. In terms of actual percentage take up of all the cohorts, so it's a similar position. We're slightly lower than last year, which was an extraordinarily successful campaign. But in terms of number of patients done, because there were much wider cohorts this year, the practices have vaccinated a lot more people. So again, it's been a very successful campaign. I'd note the flu at risk category. So that's somewhere we've always struggled as a CCG. Typically, for the last 10 years, we've been in the low 40s. This year, at the moment, we're 48%. So an increase and an improvement on sort of our standard performance for these are the under 65 patients who are at risk, so people with COPD, etc. But that's been an area where SYB as an area has struggled a bit, and I think we continue to want to improve that and get it beyond 50%.
Okay. Thanks, Andrew. Any questions or comments, Victoria?
I just think it's worth noting that our primary care networks have agreed, Sam, that they're going to continue to offer vaccinations as well. We're just working through how we can continue to deliver that as a PCN model across Bassetlaw. One of our PCNs has recognised that staff are, however, tired and probably do need a bit of a break. But I think excellent partnership working across our PCNs, I think we'll still secure a PCN model of delivery across Bassetlaw. So really, really pleased to hear that. And again, credit to the PCNs for continuing to do all that hard work. I think also it's going to be curious about the impact that it's going to have on us around the reduction in the extensive range of flu vaccinations, I think, Andrew. So I believe that they're not going to go out for as many cohorts this time as they've previously had, which would be quite helpful in terms of putting less pressure on primary care, but equally need to make sure that we get the right people vaccinated for flu that do need it. So I think it gives us an opportunity to release that capacity to focus on getting even a higher coverage for those that really do need it. But it's really good news that we'll have more capacity from pharmacists to help with that as well.
Yeah, they've dropped out a couple of cohorts. So the 50 to 64, the flu reimbursement letter came out yesterday or the day before. So they've dropped the 50 to 64 category at the moment, and one of the childhood ones, the teenager ones.
Okay. Thank you, Andrew. Sorry, on to you again. It's for approval is the primary care annual report.
Yeah, I'm going to take this as read, and well, myself and you both worked on it, Sam, and I think Victoria, you had a look at it as well, didn't you? So unless there's any comments, we'll just take this as read and approved, if that's okay.
Okay. Sue?
I just had one comment, a couple of comments. The extended hours bit, which sort of talks, I just wondered whether it needed updated, because it starts talking about from the 1st of October 2018, and the latest date it's sort of referring to is April 21, and I just wondered whether it just felt that bit perhaps hadn't been updated. And similarly on the CQC, I know, is that not been updated because we haven't had any more visits because of them not doing them during COVID? But I just wondered, that again read like it was the 21 year rather than 21-22, and we perhaps just need to say they haven't done any if that's why we haven't updated it. So that was all. Oh, hang on, sorry, the other bit was again the GP retirements. We're talking about retirements in 2021. So I just felt.
Yeah, thanks, Sue. That's odd. I distinctly I remember writing this extended access one. I'm not sure what's happened there, because I definitely recall writing and a retirement one. So I think something's gone into papers that shouldn't have done.
So maybe we've not got the most up-to-date version then, because it just felt like there were a few odd bits that hadn't been updated.
Yeah, I'm not sure this is the final version. That's the one that we've looked at. So if I'm
okay, that's fine. So if you just want to send it the updated version round outside the meeting, that's absolutely fine.
Yep. Charlotte, is that okay? Can you capture that as the next step?
Yeah, we'll do.
Thanks, Sue, for pointing that out. So we will circulate that. And are we okay to approve the annual report subject to those changes? Mick?
Yeah, mine's a slightly wider question, and I'm coming from a point of ignorance, so again, I'll apologise. I appreciate this is an annual report looking at the year just gone. I just wondered whether there needs to be anything in there, and it's both a question to my own committee as well as Bassetlaw's about the future, whether there needs to be a nod to that. And it's more of a question rather than anything else. I generally don't know what the answer is, but I just wanted to put it out there as a just to add if we were thinking about this, particularly with looking at things from a version control perspective anyway.
Thanks, Mick. Idris, do you want to come in on that? Sorry.
Yeah, I think it's a good point, Mick. And one of the things that we've been doing is working on the transition during 2021. So it's a 21, 22. See, I've done it as well now. So it's important, I think, to reflect the work that has been done to support the transition, and that gives us the opportunity to sort of point the sort of direction going forward as well.
Yeah, thank you.
So in this paragraph, I think, Andrew.
Okay.
Yeah.
So shall we make those changes and then send round for virtual approval? Is that better? Okay, we've got some nods there. Thanks everybody for that. Okay. Andrew again, sorry. This is what happens, Mick, with a small team, you see.
Not at all. No need to apologise.
We've got the extended access.
Extended access. So initially the plan was that PCNs would automatically get the extended access contracts from last year. And then this year, it's now been moved back to October. So I'll cover this. There's now a contract letter come out. It came out on Tuesday regarding the requirements of extended access, but not a full specification. I think actually, Eric, we might as well mention that now rather than under any other business. I have asked for the contract letter itself to be noted under any other business, but for the purposes of this paper, we have our 3 providers in place. So fortunately for us, we have our primary care networks delivering extended access. That has been formally stood up now again in terms of reporting back. It's been happening, but we haven't been formally contracting for it during the COVID booster campaign when that was at its height. We allowed some flexibilities for PCNs in terms of particularly reporting requirements. But that has been stood up as of next week. They'll be reporting back in again. But this is basically just to extend the extended access situation as it is now. I've consulted with our procurement team. By the 14th of March, we need to issue a VEET, and a tender waiver. So that's the intention, so that we can extend our extended access until September with the current providers. I think this will be fairly straightforward. When we issued a VEET notification initially about extended access, there was no interest from the market at that stage. So given that we know full well that the PCNs will formally be taking it in October anyway, I can't imagine there'll be a great deal of interest out there.
Okay. Any questions? We're asking for approval. And just note on the agenda, it says to note. Charlotte, can we change that? Because in the paper it's to approve. So I'll take silence as happy to approve. Thank you. And then you've got a bit of a break now, Andrew, because we'll go on to nothing on service delivery and development, and then finance. Over to Michelle for the financial report.
Thank you, Sam. So overall, as per the report, the CCG is reporting a small underspend against the funding allocated for primary medical care. This is on the assumption that the additional funding will be forthcoming around the additional roles scheme and the winter access funding and weight management. And there's very little risk to that funding now, as we've had confirmation from NHS England as to how that will work as reported previously. With regards to the winter access fund, Andrew's been working very hard with practices and PCNs and other providers to ensure that we use that we maximise the use of that funding, but it is likely that we won't be able to use all of the funding that's available to us. Similarly, in terms of the additional roles funding, it's unlikely now that the PCNs will be able to utilise all of the funding available. We did go through that exercise earlier in the year to reallocate forecast underspends, but we still will have an underspend on there. But it's important to note that we will only be funded for what we've actually spent, both on the additional roles and the winter access funds. In terms of 22-23 and the financial plan, we're continuing to work with our colleagues in Nottinghamshire, primarily to understand the funding that's available, and waiting for confirmation from NHS England national colleagues around some of those funding streams, particularly the SDF and the extended access within there, which is the largest part of funding. We need that clarity around. So we'll share information as we progress with the work on planning for next year. The initial submission of plans is due in the middle of this month, with final submission in April. So as soon as that information is available, I'll circulate it to members.
Okay.
Any questions? I can see Andrew's got his hand up.
Andrew?
Yeah, it's not a question. It's just a bit of a feedback on the Winter Access Fund. We've absolutely tried with practices, and practices have put every bit of effort in that they can to spend the Winter Access Fund. As I brought to paper last time, there's a limited menu of things you can do with Winter Access, quite rightly, I suppose. But the main one is bringing in additional staffing, and in terms of locums and how much internally they can step up their staff. There is a bit of a limitation on that, so we only really got the final approval of that, the menu of spends, as it were, in late November, and it's been difficult to productively spend all of that money. But practices have been given absolutely every opportunity to. We've still been going out to them in the last fortnight and trying to push them to spend as much of the money to improve capacity as they can.
Thanks, Andrew. Victoria?
Just reinforcing that point of view, but just to say that we've been very clear that we also are not supporting extortionate funding, because we have seen, because of the market around locum, Sam, there's been some crazy money expected, and we've been quite firm that that's not an acceptable position for us to get into. We're not getting into a bidding war with anybody. So I think what we've done is tried every effort to support the practices, and the practices themselves have tried every effort to get reasonably costed additional capacity, but we haven't supported anything that we've seen to be outside a norm.
To be fair to the practices of Victoria, when we've had that conversation, none have disagreed with us.
No, they've tended to agree. Yeah.
When we've had quotes at over £1,000 a day for locums, the practices have mentioned it. They've said, well, we have got a locum will come, but for an incredibly high amount. But they've supported us when we said we don't want to create that precedent, because otherwise, you're making a rod for your own back in April and May and further on.
Okay. So to note, we're asked to note the paper. So we will do that. Thank you, Michelle. And back onto Andrew, whether Victoria wants to come in as well on the primary care network updates.
I'll kick off if you like. I mentioned that we'd had our workforce plans. We've also we're pushing ahead with the Admiral Nurse scheme. So this is the first time when we'll have a shared members of staff. So we're going to have 2 Admiral nurses between the 3 PCNs, and we're working out a way that they'll actually work together, which I think, as well as being a great development in itself, and I have mentioned this before at the committee, is actually a really good trial run of having some shared staffing going forward. And when you've got those individual sort of high-end skills that you can't have replicated in every PCN, having that ability to move people around, I think is a great sort of forerunner of how the PCNs might work together in the future in a more collaborative way. And we're having those kind of conversations now on the back of this. Eric, you're still on the call there. How do you feel about that sort of statement? I know you sort of support the idea of the PCNs sort of moving together going forward. Not being pulled together formally, but collaborating more closely.
No, definitely. And Andrew, I'm keen that all 3 PCNs work much more collaboratively. And as you know, we've had conversations about particularly with the October changes to extended and enhanced hours and the core hours, including 9 till 5 on a Saturday, how we might get PCNs working collaboratively together there as well, delivering a wider range of services, not just GP or nurse practitioner appointments.
Yeah.
Thanks, Andrew. Victoria?
Yeah, I just think it's worth mentioning, Sam, that we are investing in some specific OD support, working with our PCNs. So this also has, again, a high level of interdependency with the wider OD package that we've got from colleagues with the place-based leadership team as well. As part of the OD support for the PCNs, we're going to have some one-to-one conversations with each of the senior leads within the PCNs, and that's going to be combined with a smaller workshop that we hope to have towards the end of April, that we're going to think about the strategic direction of PCN and collaborative working, and then a wider workshop at some point after that as well. But I think what we've already articulated within this meeting is the opportunities for collaboration. So Admiral nurses, vaccinations, extended hours. It could go into other areas that we're exploring as well around transformational change. So I think some real opportunities for that, I'm going to say, horizontal integration and alliance working. And it needs to move beyond not just the PCNs being much more collaborative, but also working with our other provider organisations in a much smoother, integrated way. In relation to that, we're also re-energising our conversations at place around workforce development and supporting that agenda as well. And that speaks to the themes of the integration white paper, which is about how do we support fluidity of people working across sectors, organisations, so that we build a sense of place team, which I think is really important to creating efficiencies of process and improved outcomes for patients. So some real opportunities, I think, Sam, really good bedrock of work we're already doing in Bassetlaw to help launch some of that work.
Okay, some great stuff happening. Thank you, Victoria. Thank you, Andrew. And that links nicely into the general workforce update. Andrew, did you want to add anything else?
No, I think they've both really, it's been mentioned, hasn't it? I think every aspect that we've covered in the last 2 months has. We've got workforce plans, as I say, from every PCN. It was good to see that the intention to recruit more core staff. I think that's the recruitment intention from our PCNs, particularly for GPs, is ambitious. I've been talking to all the primary care leads across South Yorkshire, and the general view is that it's ambitious to expand at all in terms of your numbers of GPs, and most places are really trying their best to make sure they hang on to the GPs they've got. So it's good that our intent is to expand that core capacity, and the ARS team as well. That makes it a bigger offer. What we don't want is sort of a relaxation of the core services just at the expense of the ARS services, and none of our PCNs are showing an intent to do that.
Okay, thank you. So those 2 papers were to note. On to Thomas and Digital and IT general update.
Morning. As usual, I'll take the paper as read, but I'll just pull out some key points. So back in December, we failed KPI 1, and it had been a few months. So we changed some processes and changed some staffing, and we've now successfully achieved KPI 1 2 successive months. So really pleased with the service desk. And as the paper notes, the average wait time is 14 seconds when you call the service desk. So the team are really doing some great work there, and huge improvements over previous service that was delivered. There's an issue around Retford Hospital and the shared comms room and access and ownership of kit. So we just need to, we'll be doing an audit in there and working with the other partners that utilise that room to try and make sure that all of those things are documented and confirmed, especially during transition, just to make sure that nothing gets missed. And then the final point is just around the transition and the due diligence work that's underway. There are frequent meetings to get the subgroups on track, and just to reiterate, in the infrastructure space, those relationships are being built between the technical staff in the BBS service and in the NOTS-HIS service, which really paves the way for a successful transition. So really pleased with the way that those relationships are starting to develop and in the project management space between our project management team and Nottinghamshire. So positive note there.
Okay, thank you, Thomas. Any questions? Mick?
Thank you. Thanks, Thomas. I'm afraid I'm coming from a point of ignorance there, and so not familiar with some of the terminology in the papers. But top of what is page 3 in the section around self-service usage, you've got a chart in there which is looking at incidents and services requests, and I was just trying to work out what it was trying to do, to be honest. What was the message, or what should I infer from that chart?
Okay, so the self-service portal is where you log in and you can log your own requests, either instance or service requests, through the portal rather than over the phone or by email. The number of service requests is high because largely the only way to log a service request is through the portal, because it does the auditing and the approvals. We've had a drive to try and increase the number of incidents logged through the portal to take demand off the phones. Problem is we're kind of a victim of our own success, because if on average you've only got to wait 14 seconds, it's much quicker to pick the phone up than it is to log it through the self-service portal.
Right.
So that's it's something we do want to look at in the future. Obviously, we've been prioritising other things recently.
Sure. Can I just come back, Sam, just to clarify? So what I should be interpreting is that that basically there's a lower level of self-service taking place than you would like, and
on incidents, yes, yeah.
Right. Okay. Thank you.
Okay. Any other questions? Okay. Then Sue?
Yeah. It was just about the 2 projects that are on hold, on the Tyto Care, and also, sorry, not the other one that's on hold, but the GPIT, whether the Wi-Fi, whether we're actually going to get that progressed sufficiently. It seems the GP Wi-Fi seems to have been dragging on for ages, and I just wondered if we really understand why it's not progressing, and what, if anything, can be done to get it completed.
Yeah,
I'm
so
sort of worried we might lose it in the transition if we're not careful on this one.
Okay, so the issue with the Wi-Fi is that it is future proofing. So what we didn't want to do was to spend the GP Wi-Fi allocation, buy the access points, install it, and then you transition over to NotSIS, and they have a different system, and they take the Wi-Fi points out, and they in effect become a poor investment. So to aid that transition, we've spoken to NotSIS, to look at what they've done, and we've agreed to transfer that budget so they can purchase the access points that will then be utilised for the next sort of refresh period, rather than putting it in and then having to take it out. So it has caused a delay, but it is to future-proof your infrastructure rather than just a short-term gain.
Thanks, that's reassuring. And the other bit.
Sorry, coming in. Sorry, is Victoria coming in? Sorry.
Oh, I didn't mean to interrupt. I would have waited. It was just on the Wi-Fi. There is Wi-Fi in the practices, Sue. So it's not that there isn't Wi-Fi. This is future-proofing, so that we don't have to use the tokens and things. So it's not that there isn't Wi-Fi. Rest assured. Although I did have an issue raised around Riverside's access. So we are investigating that. So yeah, I just want to rest assured there is Wi-Fi.
Thanks. Yeah.
Sue, did you want to come back in?
No, it's just the other one, the one that's on hold that looks like it's not going anywhere. Is that going to cause any problems to anybody, or is it just something that was an opportunity that we've just not been able to take because they've not responded? The Tyto Care one.
Yeah, I'll get some more information from the project manager and I'll come back, because there was some there was a note on that this week with some movement. So I'll inform everybody by email if that's okay.
That's great, Thomas. Thank you very much.
All right, Thomas, I can update on that. Tyto Care, it was an issue with the kit. So it's working with the Academic Health Science Network, and initially we were given the impression that the kit would be available to us for as long as we needed for the project to continue. So basically what it is, it's remote examination equipment, whereby a GP can actually, with a person operating it at the other end can examine somebody, can put a light down people's throat, that kind of thing, remotely. And we thought we were going to get the kit for as long as we needed. They pulled that and said we could only have it till April. And as the project was only going to start till December, and there was quite a lot of effort on behalf of the practices, so it was remote consultations with care homes effectively. So we got to work with the care homes to get the people trained to use it. We got to work with the GPs to be able to use it at their end. We haven't progressed until Tyto Care can assure us that we can have the kit for longer. We just didn't think it was really, to be blunt, worth the effort if we weren't going to have longer term access to the kit. And so we're still in that negotiation, really.
Okay. So does that answer your question?
Yeah, it does, thanks.
In a long-winded way.
All right. Thank you. That paper's again to note, and then we've got one on estates to bring Lee in to note.
Morning. Only a very quick one from me, and nothing that's not in the paper already anyway. As you know, every year NHS England run the capital funding programme, so we put forward at the early part of the year 4 schemes: Misterton and Gringley, Alves Primary Care Centre, the X-ray area at Retford Hospital, because we know that that's not used, and we did want to perhaps look at bringing it into use for some community diagnostics, and the ever ongoing dental suite issue, that we have 2 dental suites that are not used, not occupied, and whilst ever the dental suites, then we can't use them for primary care. So we'd wanted to make a decision about which of those dental suites at which primary care centre would we perhaps bring into use for primary medical care as opposed to primary dental care. Misterton and Gringley and Arworth Primary Care Centre schemes, they went forward, but there is a bit of a concern around Misterton and Gringley that I'll take to the confidential, because I didn't know about it yet, to be able to put it in the paper. I only became aware of it this week, but the Arworth and Misterton have both been approved. In terms of primary care estate strategy, Larwood and Blythe PCN estate strategy, they've been North Notts Lift have been instructed to support Larwood and Blythe in developing their primary care network estate strategy. Retford and Villages was expected to have been available in January, February time, but it hasn't come forward yet, and I will follow that up. Newgate Health and Wellbeing, we're ongoing with the work to finalise the business case. I think if I hear the term CIA modelling anymore this week, I might have to cry. But we're busy trying to work that up and complete. The next stage gate review is on the 16th of March, and there is an update to go to confidential committee around that. For the existing rejuvenation, at January, I advise that it's highly likely that we would be asked to would be requested to remove this scheme and submit a change control note. Again, that'll be discussed further in confidential committee. Kilton Forest Community Centre, I'm in early conversations at the moment with Bassett Law District Council about the possible longer term use of this building, and it may be that we invest some capital funding into there to take on the building either through a licence or peppercorn lease arrangements, but that's very, very early stages at this time. But it does appear that there's an appetite to support that, both from ourselves, from Larwood and Blythe PCN and BDC, but it is very, very early, will be subject to business case, and I'm sure subject to significant due diligence. Then just to say about the Bassett Law local plan, I mean, I mentioned this before about it all being signed up, and we are now using this as a basis for section 256 agreement with Bassett Law District Council. We know that we've got ongoing work about healthy placemaking, infrastructure, different projects across Bassett Law. We know that we've got some work to do on Bassett Law Garden Village, and we know the healthcare provision element, that's possible delivery up of a branch building that will be owned by the council and peppercorn rent back to CCG again. So it's just to note the update.
Thanks, Lee. Andrew's got his hand up.
Yeah, thanks, Lee. I suppose it's just to mention the update regarding dental services. Yesterday we were informed that the Nottinghamshire intend to include a base for the intermediate minor oral service in Worksop. So the intention is to commission that service. It was initially going to be only in Nottingham and Mansfield. There's now going to be 2 sites in Nottingham, 1 site in Mansfield, and the proposal at the moment is 1 site in Worksop. I'm not sure how that's commissioned yet. I was just informed of the intention yesterday, so I don't know whether it's commissioned as a local enhanced service with general dental services, or whether it's another provider who tends to come in and deliver it. I've asked to have a bit of a chat about it and how it might tie in with community dental services. So that's the other thing that we lack in Bassetlaw at the moment. Our patients who, so patients with learning disabilities, etc., have to go off outside Bassetlaw if they want to access community dental services. The nearest one we've got is Maltby, the next nearest is Rotherham, and it's an inequality we've always felt that needed to be addressed. So it's one of the things that we're looking forward to delegated commissioning in that respect, to see whether that can be addressed. But I don't know how this minor oral surgery service sort of sits with that, whether that's part of community dental services, because it's been an NHS England to NHS England discussion, and now involving the Nottingham CCGs, and now involving us. So it's very early days, but it's just worth mentioning that in respect to the Retford dental centre and the Harworth one, whether or not they might utilise one of them. It would seem sensible to, especially as it will also help the rest of Nottinghamshire. It might help cover the Newark area if you had a Retford site.
Yeah, I was just going to say, Andrew, totally support that, and I just wonder, Notts colleagues, if they know our dental demographics locally. I would be incredibly surprised if there is a dentist and suitable infrastructure in Worksop. I will be really surprised. So it's more likely that would have to be Retford and Harworth, and actually that would bring it into use. And then just to follow up on the community dental, just to be really clear, it has not always been an inequity. This was something that NHSE, and Nick, I'm not being derogatory when I say this, NHSE re-procured the service, and some of the activity that was commissioned to community dental went into Bradford, where there was a greater need, and we didn't get coverage in Bassetlaw. So it's been an ongoing 4-year thing in equity, but it never used to be the case.
Yeah, I think in terms of the supply, I think there's been a patient consultation, and I suppose naturally the patient consultation is likely to gravitate on Worksop. I don't think it's considered the actual provision side of it at this stage.
Yeah,
so done the right thing, absolutely done completely the right thing.
Absolutely,
but when it comes to the conversation, it might actually, when we look at the way the service delivery model, it might actually work well out of Retford. I would say that's going to cover a larger area as well.
Well, we know locally, don't we, that our patients, when we have done our local engagement, they wanted Retford, not Harworth.
Yeah.
And at one time we did have the area in Worksop at Newgate, and it was still Retford that people wanted. And I don't know if that's because the community dental services have got a bigger cohort of people with learning disabilities, or who might access dental services in that area. I don't know, because I didn't do any benchmarking around that, but it could be that that's the case.
I suppose thinking about it, a lot of our learning disabilities homes are in the Retford PCN, Retford Villages PCN. We've got a large cohort there, so
yeah.
Okay. Any other questions or comments for Lee on the estates update? Okay, thank you, Lee. The next 3 items on the agenda, and I'll turn to Sue here as well. We've got items for escalation to QAPs, governing body and audit. I wouldn't say there is any, however, I'll take your view, Sue, as well.
I'd agree. I don't think there's anything.
Okay. Thank you. And then
Sam, I will report the COVID and flu as usual, though, to QAPs next week. So it won't be escalated to them, but they'll be fully informed as well. And we'll have another discussion about the plans there as well.
Okay, thanks, Andrew. And then on to risk. Item 14 on risk management and Alternative Victoria. We just got the one risk on there on the workforce resilience due to the pandemic, with an update there in February. Victoria, do you want to add anything else?
No, I don't think so, Sam. I've just proposed really that we reduce the risk, and we did actually pick this up in a roundabout way at audit, didn't we, yesterday?
Yeah. Okay. Sue, do you want to come in on that conversation from audit yesterday?
Yeah, I mean, I think I haven't got a problem with reducing the risk, to be honest. I think it fits, doesn't it? We've developed it quite well. We've addressed the key bits of it. I think it's the likelihood's gone down, if anything.
Okay, so we're asked to reduce the risk to 2 by 2 to 4. Things do seem, I suppose, more settled in primary care at the moment with staffing. However, we're aware that this risk could fluctuate depending on if there's another outbreak. So committee happy to reduce to 4 on this risk?
Do you want to go that far? Do you want to leave the impact at 3 and the likelihood at 2?
Okay.
I don't know.
Victoria?
Yeah, I'm happy with that. I'm comfortable that it's still on though. We need to maintain it. I don't think it's something that we want to drop off the agenda completely. It's such an important part of ongoing resilience, isn't it? Workforce, as we discussed in audit yesterday. So I'm comfortable with that. I think for me, it's acknowledgement that it is definitely not where it was.
Yeah. I'd feel more comfortable with leaving the impact as it is, because I think and it's the likelihood that's dropping at the minute, I think, because of what the mitigations we've got in place.
Yeah.
Okay. Mick?
To be honest, it's just been said really. You know, certainly workforce is a really big issue, and from my perspective, what's just been described probably seems a sensible way forward. Recognising from what's been said, there's an improvement, but therefore the likelihood goes down, but the impact is certainly still, I would say, the same.
Thanks, Mick.
I should have just shut up there, shouldn't I? Just to agree with what Sue and Victoria were saying at the end. There you go.
Andrew?
Yeah, just to note, we mentioned it earlier, the Winter Access Fund ends soon as well, so quite a bit of the support. We are looking to support the practices and the PCNs going into the spring, but in terms of the big resource that was available centrally, it does end soon.
Okay. So committee will agree to reduce the risk, but we'll reduce it to a 6, and we're aware that this could increase again depending on pressures. And then identification of any new risks or IGR security information risks. Can't think of any unless anyone else wants to add anything. Okay. And any other business? Okay, so that's the end of the public session. We can stop recording the meeting. Mick, what we do is we have 2